Hello everybody, this is Dr. William Pientka from theorthopods.com. In this new lecture series, part of the free online access to medical education initiative, or FOMED, I plan to cover the basics of orthopedic surgery. These lectures are not going to make you an orthopedic surgeon. However, they will give you an overview of the basic principles by which orthopedic surgeons operate. These lectures are geared towards medical students who may or may not have an interest in orthopedic surgery, as well as interns and lower-level residents. As an orthopedic surgeon, I feel that the entire medical community can benefit from the increased awareness overall among all medical practitioners of the basics of the musculoskeletal system and its disorders. Today, I'd like to begin our initial podcast on the initial evaluation and resuscitation of the trauma patient. There are classically three peak times of death following significant trauma. 50% of trauma patients that do not survive their traumatic event will die within the first few minutes of sustaining the injury. These deaths are mainly caused by massive blood loss or severe neurologic injury. There's a second peak of death following major trauma within the first few days after the incident, and this is most commonly from a significant neurologic injury. The following 20% of patients who die from trauma will die within the first days to weeks after the injury, and this is usually the result of multi-system organ failure or overwhelming infection. Many experts talk about the golden hour in trauma patients. This golden hour refers to a period of time when the life-threatening and limb-threatening injuries must be treated in order to decrease the mortality risk for that patient. Experts estimate that approximately 60% of preventable deaths can occur during this time. This is why it's important to quickly evaluate and resuscitate these trauma patients. A standard ATLS protocol has allowed for standardization of the initial evaluation as well as resuscitation of these trauma patients. As a physician who will be treating trauma patients, it is important to familiarize yourself with the ATLS guidelines. ATLS protocol dictates a standard moniker for how trauma patients are to be evaluated. This includes the ABCDE mnemonic. A, standing for airway, also includes control of the cervical spine in a trauma patient. A quick way to evaluate the airway in a trauma patient is simply to ask them to tell you their name upon initial arrival into the trauma bay. If the patient can talk to you, then you've established that they have a patent airway at that particular time, as well as adequate breathing necessary to sustain speech, and you may move on to the next portion of the ATLS primary survey. If the patient cannot talk to you, however, you must ensure that they have a secure airway before moving on to further evaluation. Securing an airway for this patient can mean several different things. This may mean the patient requires intubation. Intubation would be indicated if the patient has a Glasgow Coma Scale, or GCS, less than 8. The easy way to remember is the saying intubate if less than 8. Also, significant facial trauma or altered mental status, or severe combativeness which interferes with the medical treatment, may indicate a need for intubation. Sometimes, due to facial trauma or a difficult airway, an intubation is not possible in a safe or timely manner. If so, a cric, or cricothyroidotomy, would be necessary to establish an emergency airway for these patients. This can be formalized once the patient is stabilized and out of the ER setting, and this is usually done by a general surgeon. B, or breathing, is the second portion of the initial trauma evaluation. This is where breath sounds are auscultated. It is important to note that if the patient has decreased breath sounds on one side, this may necessitate the placement of a chest tube. You also want to assess for the quick killer in trauma patients, the tension pneumothorax. This should be suspected if a patient has decreased breath sounds on one side and engorged neck veins with shifting of the trachea to the opposite side. If a tension pneumo is suspected, the chest should be immediately decompressed using a large bore needle in the second intercostal space in the midclavicular line. This should be immediately followed by chest tube placement. Never wait for a chest x-ray if you suspect a tension pneumo. The patient may be dead by the time you get it. Moving on to the next portion of the primary survey, C, for circulation. It is in this portion of the primary survey that you want to identify any massive hemorrhage that may be occurring and begin resuscitating the patient. This resuscitation begins with 2 large bore IVs immediately as the patient rolls into the ER and 2 liters of normal saline or lactated Ringer solution. Things that you should do to assess circulation are first, assess for pulses. You want to check for dorsalis pedis as well as the posterior tibial pulse at the ankles. You want to check for a femoral pulse in the groin. And other pulses you want to check for are radial pulses as well as carotid pulses. The standard moniker is that if the patient has a radial pulse, their systolic blood pressure should be at least 80 millimeters of mercury. If the patient has a femoral pulse, their systolic blood pressure should be at least 60 millimeters of mercury. and if the patient has a carotid pulse, their systolic blood pressure is at least 40 millimeters of mercury. I call this the 80-60-40 rule. How is this useful clinically? You use this information to determine if the systolic blood pressure correlates with the physical exam findings. I've received many consults for pulseless extremity in a patient with a blood pressure in the 60s. This patient may or may not even have a femoral pulse with that systolic blood pressure. These patients are underperfusing their extremities. However, this is largely correctable through fluid resuscitation. In a patient with a systolic blood pressure of 70, you wouldn't expect to feel a radial pulse, and thus you may not consider that a pulseless extremity in the standard sense. It is possible that they have significant trauma to that extremity, and even with resuscitation, they will not have pulses. However, you cannot say it's pulseless until you have an adequate perfusing pressure for that extremity. There are several ways to follow and measure the resuscitation status of patients in the trauma bay. The most obvious thing to do is to follow the vital signs for the patient. Arterial lines can allow for an instantaneous measurement of arterial blood pressure and is helpful to monitor the patient in the acute setting as well as in the ICU. There are other indicators of adequate resuscitation in the patient that you want to look for. These include a heart rate less than 100 beats per minute. Also, you can follow the patient's urine output, which you would expect to be approximately 30 milliliters per hour or 0.5 to 1 mLs per kilogram per hour. The most sensitive indicator of adequate perfusion is the serum lactate level. When the serum lactate level reaches normal, which is less than 2 millimoles per liter, this indicates that circulatory beds have been adequately perfused. Another lab value to follow is the base deficit, which is normally in the -2 to +2 range. Significant deviation in the base deficit is indicative that the patient has not been adequately fluid resuscitated and may not be ready to go to the operating room. As far as blood management for trauma patients, it's important to know what the estimated blood volumes are for an average-sized adult and an average-sized child. The average adult, which classically refers to the 70-kilogram male, has an estimated blood volume of approximately 4.7 to 5 liters. An average child, in the range of 2 to 10 years, is approximately 75 to 80 milliliters per kilogram of circulating blood. In the adult trauma patient, if they receive their initial 2 liters of crystalloid upon arrival without the ability to stabilize their vital signs, this patient should be emergently transfused packed red blood cells. Classically, trauma patients were given a ratio of 1 to 3 of red blood cells to platelets in fresh frozen plasma. However, newer data is suggesting that trauma patients do better if you give them a ratio of 1 to 1 to 1 of red blood cells to platelets to fresh frozen plasma. What this does is help prevent the coagulopathy that these patients who receive multiple blood transfusions tend to develop, which can be life-threatening. So where do trauma patients bleed from? If they have an open wound with extravasation, the answer is much more clear. But don't be fooled. They could be bleeding from multiple locations, and it's important to remember that there are several compartments of the body that can hide a large amount of blood without being too clinically apparent. For example, the retroperitoneal area can hold a significant amount of blood that will not be clinically obvious upon initial evaluation. If a patient's bleeding into the belly, usually they have signs of an acute surgical abdomen, and that'll be clinically apparent, or apparent on a fast exam. However, they will not have these signs if their bleeding is retroperitoneal. The thigh is another area of the body that can hide a lot of blood. For example, approximately a liter of blood can rest in the thigh and not be overwhelmingly obvious. If the patient is persistently hypotensive, which is not responsive to fluids, then you may want to look for bleeding in a less obvious location. In addition to assessing pulses with circulation, you want to do a fast exam, which is the focused abdominal sonogram in trauma. What this looks for is free fluid in the abdomen, which could be a sign of intra-abdominal bleeding. It also looks at the pericardium for free fluid around the heart in the form of a pericardial effusion. A pericardial effusion in trauma could lead to pericardial tamponade, which is external compression on the heart from fluid within the pericardium. This could be a quickly devastating complication of trauma that has a relatively easy fix in a pericardiocentesis. If for some reason an ultrasound is not available to do the fast exam, you can do a diagnostic peritoneal lavage, or DPL. This involves injecting some saline into a small nick which is made periumbilically, and then removing this fluid and evaluating it for the amount of red blood cells. This is becoming less and less in favor in trauma, given its invasive nature. The next portion of the primary survey is D, or disability. This is the portion of the survey where you assess the neurologic status of the patient. The Glasgow Coma Scale, or GCS, falls under disability in the ATLS protocol. The Glasgow Coma Scale is a quick and easy way to determine the overall neurologic status of your patient. This is a fluid scale which will change as the patient undergoes either neurologic recovery or neurologic deterioration. The GCS is broken into 3 categories. The 3 variables that make up the GCS score are motor response, which is on a 1 to 6 score, verbal response, which is a 1 to 5 score, and eye opening, which is a 1 to 4 score. The way I like to remember this is from medical school, where a V6 car, or a motor vehicle, has 6 categories, like a V6 has 6 cylinders. For eye opening, I remember 4 eyes. Eye opening is on a scale of 1 to 4. The remaining category, verbal, is on 1 to 5 score just by a process of elimination. Again, V6, like a V6 car or automobile, is the motor category 1 to 6. 4 eyes for eye opening 1 to 4, and the remaining variable is 5, which is verbal. The overall GCS score ranges from 3 to 15. As we stated previously, the classic indication for intubation was a GCS score of less than 8. This is a neurologic status in which the patient is likely to not be able to maintain their airway independently. Let's dive a little deeper into what the variables within each GCS category represent. In motor, remember V6, there is a range in score from 1 to 6. The patients will receive a score of 6 if they obey commands. If the patient is not obeying commands, you may squeeze their fingernail or do a sternal rub. If the patient localizes the pain, meaning that they take their other hand and move it toward the painful stimulus, this will give them a motor score of 5 for localizing to pain. If the patient has a normal withdrawal from pain, meaning they take the hand that you're squeezing on the fingernail and they pull away from you, this would give them a motor score of 4. If the patient is exhibiting decorticate or flexion type posturing, this is an abnormal response, and we'll get 3 points in the motor category for this. If the patient has abnormal withdrawal with extension, this is cerebral posturing, decerebrate posturing, and correlates with a score of 2. If there is no motor response and the patient is flaccid, they will receive a score of 1 for motor. Very commonly, people get decorticate and decerebrate posturing confused. The quick and dirty way I remember it is E in extension goes with the E in decerebrate. In the Glasgow Coma Scale, the verbal response again is scored from 1 to 5. If the patient's speech is oriented and appropriate, they will receive a full score of 5. If the patient's speech is coherent but confused, the patient will receive a score of 4. If the patient's speech is incoherent or inappropriate, they receive a score of 3. If the patient is just making incomprehensible sounds, they receive a score of 2. This includes moaning. If the patient makes no noise, they receive a score of 1 for verbal response. The final category under the Glasgow Coma Scale is eye opening, which again is scored from 1 to 4. If the patient opens their eyes spontaneously, they receive a score of 4. If you need to verbally prompt the patient to open their eyes, but they do open them to speech, then they receive a score of 3. If the patient does not open their eyes to speech, but will open their eyes to a painful stimuli such as a sternal rub, they receive a score of 2. And if the patient does not open their eyes, they receive a score of 1. The overall calculation of the Glasgow Coma Scale is the best motor response plus the best verbal response plus the best eye-opening response. The total will range somewhere between 3 and 15. How the GCS score is commonly interpreted is a severe brain injury has occurred if the GCS is less than 9. A moderate brain injury has occurred if the GCS is 9 to 12. And a minor neurologic insult has occurred if the GCS is 13 or above. The GCS does have some limitations, however. It does not take into account lateralizing signs. It does not take into account metabolic processes that could be affecting the neurologic status, such as hypoglycemia. It also does not account for intoxication. For this reason, it's important to repeatedly assess the GCS as you continue to evaluate your patient. Again, classically, the GCS less than 8, that patient should be intubated to protect their airway. If the patient has been intubated by EMS in the field and they're sedated in the ER, their GCS will likely be a 3T, with the T standing for tubed or intubated, and this indicates that the patient is not without the sedative effects which are affecting their neurologic status. The final portion of the primary survey is E, or exposure. Exposure means taking all coverings and clothing off the patient and fully examining the body for evidence of previously unrecognized trauma. This means taking off splints that were placed at the field or an outside hospital prior to transferring the patient. The reason we take off splints on these patients is because it's not unheard of to miss an open fracture that was splinted at an outside hospital for transfer. This could lead to a devastating infection for the patient who was treated closed when they had an operative indication, meaning an open fracture. You'll also want to log roll the patient to palpate the spine and look for any perineal lacerations. The final and most critical point that I'm going to make on the ATLS primary survey is that at any point, if the exam changes while you're performing the primary survey, you must go back and start again with A. This means that if you're checking pulses on a patient who was previously breathing spontaneously and your nurse tells you they're becoming less and less stable, you must go back and reassess the airway as their situation has changed. And do they have a need at that time for intubation to have an airway provided for them? Now that you've finished your primary survey, it's time to talk about bones. There are certain types of fractures that tend to bleed a lot in trauma patients. Like I said before, the thigh can hide a lot of bleeding, and this bleeding generally comes from a femur fracture. The leg can hold less blood, but still a significant amount of bleeding can occur with a tibia fracture as well, especially one that's open. In a multiply injured trauma patient, the goal is to stabilize long bone fractures and address immediate life-threatening concerns as soon as possible. This is where the concept of damage control orthopedics comes into play. Damage control orthopedics involves quick, rudimentary ways of stabilizing long bone fractures in people who have life-threatening injuries. This involves placement of pelvic binders or sheets wrapped around the pelvis in people who have an open book type or APC type pelvis fracture. The pelvic binder is not helpful in lateral compression type injuries where there's not an increased intrapelvic volume. It is increased intrapelvic volume type fractures where there's tearing of the posterior vasculature in the pelvis that leads to significant hematoma and bleeding into the true pelvis. By quickly decreasing the intrapelvic volume using a pelvic binder or a sheet wrapped around the pelvis, you can decrease the amount of bleeding and help stabilize the patient hemodynamically. Other things you can do in people that are multiply injured and are hemodynamically unstable is to place an external fixator. The external fixator is great for stabilizing long bone fractures, which will help stabilize a clot and help tamponade bleeding within the extremities. Once the patient's in an external fixator and their life-threatening injuries have been stabilized by the intensive care or trauma surgeons, you can consider converting them to formal fixation, usually with open reduction internal fixation or intramedullary nailing. You can decrease what's known as the second hit phenomenon by utilizing damage control orthopedics. The initial hit is the trauma insult to the body, which causes a drastic inflammatory response, which can be overwhelming to the trauma patient. By stabilizing their long bones and not further insulting their system with the trauma of an open reduction internal fixation or intramedullary nail placement, you can allow them time to recover from their initial injuries before converting them to formal fixation. This idea led to a significant decrease in the mortality for these multiply injured trauma patients over the past 20 years. In upcoming lectures, we'll talk about the management of open fractures. I also plan to talk about the management of most commonly encountered significant traumas that can be life-threatening. This includes femur fractures as well as pelvic fractures. I plan a separate lecture on the topic of compartment syndrome, which is also very important in orthopedics. We'll also cover more of the idea of damage control orthopedics in future lectures. If you have questions or comments, I can be contacted on Twitter via _orthopods or on theorthopods.com via the Contact Us section. If there are topics you'd like to see covered, please let us know as we continue to grow this lecture series into the most helpful series possible. Thank you, and have a nice night. Have a nice night. Have a nice night.